Today, we're specifically focusing on part 5 of chapter 4. And we're going to start right here with the subcostal view. So when you get to the subcostal window, this is what it's going to look like right here. This is what's in your book, but I put this little loop right here just so you can see what a normal one would look like. And what we know the subcostal window for, it's the ability for it to let us visualize the anterior and posterior parts of the heart. So in order to acquire this view, we're going to ask the patient to lay supine or flat on his or her back. And part of the charm about this particular window is it has many advantages. One, there's no bone or lung tissue to kind of block our view to the heart. And it also allows us to be able to image the patients from the supine position to be able to see everything properly. So once we're familiar with the subcostal window, we're going to find out that it is a really good substitute to the parasternal and apical windows, and that also sometimes it actually even gives superior images to these windows. Remember, some pathology sometimes can only be seen in this window. So to approach this, we put the transducer just below the xiphoid process and with the indicator facing towards the person's left side. So we'll increase the depth, but that's to check to see if the person has pericardial effusion and check out the surroundings in case they have an extracardiac mass we would like to show the doctor. We're then going to decrease the depth. We'll check the chamber size, how thick the walls are. Is the heart functioning normally, globally? What are the valves like? Does the person have regurgitation? And we'll measure that RV wall thickness in end diastole, that RV free wall. So we use color flow Doppler. I've never used M mode, but your book recommends you use M mode. I've never used M mode, but it is valuable if the person has diastolic dysfunction. And we would use spectral Doppler if the person has regurgitation to check to make sure that those are looking good. So one of the main things that we would assess in this view is what we call cardiac tamponade. So this is what's in your book, but I found these two looped clips right here so you can see what tamponade actually looks like. But before I go into that, let me talk about this right here. So you see A, B, and C. What A is trying to show you is what we call LHIS, or lipomatous hypertrophy of the interatrial septum. What it does is it gives the interatrial septum like a dumbbell shape, and commonly we will find these in people who are elderly. Now, B is what's showing us that diastolic collapse because of a pericardial effusion with hemodynamic compromise, aka cardiac tamponade. So for us, this is always bad. It means the person definitely has tamponade. The third one is not a very good image, but it's supposed to represent a prominent Chiari network. And the Chiari network is a mobile net-like structure that can occasionally be seen when we do an echo in the right atrium near the opening of the IVC and the coronary sinus. So for us, this usually has no clinical significance, and it's often that we diagnose it accidentally. So let's get to cardiac tamponade. Notice the first thing is the person has to have a pericardial effusion. It can be large or small, but when we call it tamponade is when it has hemodynamic compromise. Please remember that this is a serious medical condition and where the blood or the fluid fills the space between the pericardial sac and it encases the heart itself. So what happens is it places extreme pressure. I'm going to use this one, but subcostal is normally where we would see it. It places extreme pressure on the heart, and then the pressure prevents the heart or the ventricle of the heart, sometimes even the atria, from relaxing and functioning properly. So these video images are showing the right ventricular collapse. Notice in diastole, it's like bowing into the wall is bowing into the LV chamber. So that's what we call RV collapse, and it happens in early diastole or the end of the T wave in a patient who has cardiac tamponade. Remember, This is always an emergency, so for us in a hospital, this will be a critical condition. After you've done this, let's say you weren't able to get the short axis, you would try to get the short axis in subcostal. And so the subcostal window, again, can be a good view for people who have like COPD or some type of lung problem that obstructs the view. So the subcostal window and the views are absolutely necessary, like in a pediatric exam, because they kind of lay out the anatomy in relation to the surrounding structures. But in an adult, this is what it's going to look like. This is if you weren't able to see it anywhere else. So you'd rotate the probe 60 to 90 degrees counterclockwise from the subcostal forechamber. So obviously we want a 2D image. The color flow spectral is when you do your pulse wave Doppler. And again, if the person has COPD, it's going to be a little bit difficult to be able to see. And this is a good view for people with COPD if you could not see from the normal subcostal, from the normal short axis. I'm sorry, not subcostal window. All right, so your subcostal IVC. So what we want from the IVC is the diameter, what we're measuring, and the inspiratory collapse to tell us like if the person has elevated right-sided heart pressures. So we're gonna angle medially from the base of the short axis, and it helps us estimate the mean right atrial pressure. Now, us as the sonographer, we would add 3, 8, or 15 to the number that a formula that the machine works out gives us. We've talked about this already. The normal IVC diameter is from 1.2 to 2.1. So when they measure from here to here, because this is what it'll look like, but then you turn on M mode and it gives you this. So if you measure from here to here and it measures more than 2.1, the person has a dilated IVC. You're then going to have the person take a sniff in. If it closes more than 50%, we add 3. If this number is less than 2.1. If this number is greater than 2.1 and this does not maybe close 50%, we add 8. If this number is greater than 2.1 and when the person takes a sharp sniff in, nothing happens, we add 15. Just a quick reminder. So on this view, though, we should be able to see the inferior vena cava as it enters the right atrium. So this is the IVC, and this is it entering the right atrium. We should also be able to see the hepatic veins, which is what we see right here, and right here. So remember that hepatic veins drain into the IVC below the diaphragm. So, and in some patients, you might be able to view the superior vena cava, but like that's way, way, way over there. It depends on the patient's anatomy, and what we call that will be the far field. So, this view has very different uses, and we use it for assessing the size and blood flow of the inferior vena cava, like I just described, the hepatic veins, and we can identify a prominent eustachian valve and pericardial effusions as well. But remember, again, the eustachian valve is not seen in everybody, and we don't use it as adults. So after that, we can also take a look at the subcostal descending aorta. This is the descending aorta right here from the subcostal view. And remember that diameter should normally be less than 3 centimeters. So when we look at this, we will also compare it to the ascending aorta. And remember, both the ascending aorta and descending aorta should be 3 centimeters or less. And we will check them with continuous wave Doppler, and the velocity should measure less than 2 meters per second. So for us, the subcostal descending aorta is good if we want to assess coarctation of the aorta. And it typically would manifest as a blunted low velocity spectral Doppler flow. And the flow is going to be persistent through diastole. Remember, in diastole, the aorta is supposed to be closed, so there's not supposed to be any movement, really. But when the person has that coarctation of the aorta, you're still going to notice blood flow. So the very last image we normally get in echo is the suprasternal long axis. So that's the suprasternal notch. So it's between the person's collarbones, the center of them, in the middle of their neck. And the indicator would normally be towards the patient's left ear, or sometimes even straight up to that person's chin. So we use this suprasternal window to measure the width of the aortic arch. And we also look for aortic dissections and coarctations. So I'm going to show this little video right here. When you measure the aortic arch, you'd measure from here to here. Make sure it's a leading edge to leading edge. If a patient had coarctation of the aorta, it'll show up right here. This would be extremely narrowed, and there's going to be turbulent flow right here. So we would also check for retrograde flow right here. So you know how this flow is blue? If it looks like it's red coming back up this way, that's not good. So we're checking to make sure that there's no retrograde flow in the descending aorta, and that's why we use color Doppler, and we're checking for aortic regurgitation. Now, the patient should be positioned in the supine position with their neck extended as far back as it can go. So you're going to want that neck to be tilted again as far back as possible. And we can also put a pillow under the patient's shoulder to help with their positioning. It is easier to image young people because they're able to extend their neck much farther than sometimes older patients who've had injuries and things like that. Quick tip for you. Patients who have emphysema or COPD are going to be kind of difficult to image because the air in the lungs obstructs the view of the sonographer. So to help alleviate this, you want to ask them to exhale during the time that you're doing the exam. So real quick, the suprasternal long axis is supposed to show you the ascending aorta. That's this right here. It's going to show, and it'll be on the left side of the image if you're oriented correctly, the aortic arch right here, and the branches of the aortic arch that it's going to show you is the brachiocephalic artery, which is this right here, the left common carotid, which is this right here, and the left subclavian artery. And then sometimes it'll show the cranial segment of the descending aorta, which is this right here. So right here, ascending aorta, aortic arch, brachiocephalic artery, left common carotid, left subclavian, and the cranial segment of the descending aorta. This is just images of what it'll look like. You want to show the ascending aorta, the aortic arch, and the descending aorta. Always remember that where you see this flow, break in flow, there's nothing wrong. What's happening is no echoes are being sent back because it's perpendicular. With color flow, you want the flow to be parallel. If it's perpendicular, you're not going to see anything. So ascending aorta will be above the baseline. Descending aorta will appear below the baseline. Now, when you are done with your exam, there's a few things that you need to make sure. Run through your exam to make sure that you got everything before you let the patient go. Review images and delete the ones you don't want before you end the study, and then end the exam after you've checked all your numbers and you're okay with them. Also, you're going to want to transfer the images to what's called a PACS system so the doctor can get to it whenever he has time. Wipe off the gel, remove the electrodes. Also, lower the bed if you've raised it up for your comfort so that the patient does not slip and fall when they're stepping off the bed. Remember, some of these people are quite old. If the patient asks your opinion, never give them any answers. Remember, your job is not to diagnose. Your job is to do the exam, and a cardiologist or their primary care physician is the one who's going to give them the results. After the patient leaves, wipe down the machine, make sure you disinfect the probe, and make sure that everything is clean for the next patient. Also, get yourself a preliminary report. That's the report that you do on whatever system you happen to be using where you work before you send it. We don't normally use paperwork anymore unless it's a stat, and you keep the stat normally for CYA purposes. Um, some cardiologists will allow you to read with them. That's very helpful because you learn a lot. Not all do, but some do. You always want to review that final report and then make sure that the doctor gets it in a timely manner. Usually, if it's a stat or critical, you want to inform them when you begin and right when you send the study so that they can read it right away. If it's an emergency, do not text them, call them. So we've talked about diastolic function before, and according to the ASC, LV diastolic dysfunction is usually a result of impaired left ventricular relaxation with or without reduced restoring forces. Basically, the heart is going to try to fix itself at first. And it also is a result of increased LV chamber stiffness, so which is going to increase those LV cardiac pressures. So what we're going to be looking for is impaired LV relaxation, aka is the left ventricle not relaxing properly? Are those forces that'll normally kick in reduced? And is the diastolic part of the heart, is it stiffened? Is it causing more issues? We're going to estimate the LV filling pressures. We're going to evaluate the heart rate, the rhythm, the blood pressure, and the EF, but you should have taken the blood pressure right when the patient came in if a nurse didn't do it. You'll check for mitral valve disease. We'll capture both the volume using the biplane method of the left ventricle and the left atrium. We'll check the wall thickness. Normally, we've already checked this in plaques. Doppler patterns, timing, all that. We will check LV diastolic function, and then we should always make a remark on our report on whether there is like impaired relaxation, restrictive filling, normal, or really, really bad situation that the doctor needs to take care of right away. So when you're looking at your waveforms, just a few tips. You do not want to, by the way, these tips don't apply to children or adults who have arrhythmias because their heart rates are going to be irregular anyway, hypertrophic cardiomyopathy, restrictive cardiomyopathy, valvular heart disease, or things like that. So you also do not want to measure suboptimal Doppler signals. Do not use those. Make sure you have a very good signal because the more accurate your study is, the better the doctor can diagnose that patient. So we're always going to be wanting to look for two or more similar waveforms before we take them for our calculations. Do not measure like the one normal or the one abnormal waveform when we use spectral Doppler. That's what this is. Choose one that looks similar to the group. So if you have 4 of them that have this height, and then you have a taller one right here for an E wave, don't use the taller one. Pick one of these 2 that look more similar. We need to remember one thing. You see how normally the E wave is going to be taller than the A wave. For this right here, the E wave is shorter than the A wave. This, if you see it in a young person, is abnormal. But if the patient is over 40, it is no longer abnormal, so it's going to appear normal. So the normal filling patterns in the elderly may resemble the filling patterns, abnormal filling patterns of younger people. So again, when a young person has mild diastolic dysfunction, that's what it's going to look like. It's called impaired relaxation. The E wave is going to be smaller than the A wave. Remember, that can be normal for elderly patients. I'm going to want for you to read in your book page 106 to 117, just so you can get a better grasp. This is your E wave, peak velocity, your deceleration time, and your A wave. I just wanted to show you. Again, what we're using this for is to get that EA ratio. We'll check the deceleration time and the A wave duration. Many people don't measure the A wave duration. A wave duration, it looks like an H. They're going to measure from here to here. Then we're going to turn on tissue Doppler. We measure the lateral annulus and the medial annulus. It honestly doesn't matter in which order you do it because the machine wants an average of it. We're going to acquire the LA volume index. And for the pulmonary vein flow, you're going to see your S wave, your D wave, AR duration, and SD. Remember, your pulmonary vein flow is right here, right down here. So you grab this pulse wave Doppler and you put it right there. So we also get the peak TR velocity if the person has regurgitation. For somebody with impaired relaxation, like what we saw right here, this is called impaired relaxation, you're going to ask the person to do a Valsalva maneuver. And when we do this Valsalva maneuver, we're checking to see if there's an E and A wave reversal. If there's a reversal, then it means that the person definitely has an issue, and it's like grade 1 diastolic dysfunction. Normally, this is what it's going to look like. Your E wave is going to be taller, you have your deceleration time, and your A wave is going to be shorter. And your A wave duration is this thing that looks like an H from here to here. So again, number 1 is representative of your E wave peak velocity. Number 2 is representative of your A wave peak velocity. We're going to get an EA ratio, and from 1 to 1.5 is considered normal. Your deceleration time is going to be between 160 to 240, but normally it should be less than that 160 for normal, actually. Your A wave duration, that's what we're going to be measuring right here. Now, this is acquired in apical 4 chamber. Always tilt the heart to make sure that the pulse wave gate is parallel. And you want to put it at the tips of the mitral valves. And you want it to be parallel to the flow, not the valves, the flow. Again, at the tips of the mitral valve leaflets, inflow. That's where we want it. So again, one more time, this A wave duration is what looks like an H in the picture. So what it's going to measure is, it's the timing from the beginning of the A wave to the end of the A wave. So for the EA ratio, what you're going to do is take the E and divide it by the A. So for this one, to get the EA ratio, you would take 1.2 divided by 1. So your EA ratio would be 1.2. For this one, on the other hand, where this person has impaired relaxation, this is normal, this is impaired relaxation. The person is going to have, you have 0.8 for your E wave and 1.2. So you will take 0.8 and divide it by 1.2. This person's EA ratio is a 0.7. So we're going to turn on tissue Doppler. And remember, we measure that medial annulus and the lateral annulus. So both the lateral wall and the septal wall. By the way, the septal wall is where your medial annulus is, and the lateral wall is where your lateral annulus is. So remember, your anterior mitral valve leaflet, posterior mitral valve leaflet. So when you put this E-wave situation, these are the things that you're looking for. You're going to be looking for your E prime and your A prime. Remember, this should look like the mirror image of what you got right here. So you see how this looks like this right here? If it's normal, it's going to be flipped upside down. The E wave is still going to be taller than your A wave. This is your S wave, but we don't worry about that too much. This is your isovolumetric relactation time, or IVRT. We talked about that a little bit, but don't worry about that. What matters is this E prime and A prime, but specifically this E prime. So if you have an E to E prime ratio of less than 8, it indicates that the person has normal LV filling pressures. If your E to E prime is greater than 14, it indicates that the person has increased LV pressures. So let's talk about this diastolic functions or diastolic dysfunctions. Memorize these pictures. Normally, your E wave is going to be taller than your A wave. Impaired relaxation is when your E wave is shorter than your A wave. That means that the person has grade 1 diastolic dysfunction. Remember, this is going to be normal in nearly 100% of individuals by the time they're 60 years old. It's only abnormal in young people. As we age, this slowly goes to this. So that's what I need you to remember for that. There are numbers, but don't worry about that. Grade 2 diastolic dysfunction. Now this definitely tells the doctor that the person has elevated pressures. So in order to separate this from this, you're going to ask the person to do Valsalva. If they do Valsalva and this does not become this, it means that the person is normal. If they do Valsalva and this turns into this, it means the person has pseudonormal, which means they have grade 2 diastolic dysfunction. Let's move over to grade 3. Grade 3 and 4 are both restrictive, but they're both called restrictive diastolic dysfunction, but one of them is reversible and the other one is not reversible. So for both of them, it means that the person has significantly elevated left atrial pressures. That's why we call it a restrictive filling pattern, because it's not allowing the atria to fill properly. Just keep that in mind. So I don't want to talk about numbers, but if you do this, if the person looks like this, the E wave is going to be much taller. If you notice, this is not that tall, but it's still taller than A. For restrictive, the E wave is going to be much taller than the A wave. And then when you ask that person to do Valsalva, it'll go back to grade like 1. If it's non-reversible, when you ask that person to do Valsalva, nothing will happen. So that's what separates this from this. So I have a few images that I want you guys to study on your own, just to kind of help you understand diastolic dysfunction. So what this is showing is your normal pulse wave. When you put that normal pulse wave at the tips of the mitral valve, if it looks like this, it's normal. If it looks like this, it's grade 1. If it looks like this, it's grade 2. If it looks like this, grade 3. If it looks like this, grade 4. Remember, this can be reversed with Valsalva, this cannot be. So when you do your tissue Doppler, remember this is supposed to flip upside down to look like this. So the E wave is still taller, just like how it's taller here. For grade 1, the E wave is still shorter. For grade 2, even though the E wave, when you do the pulse wave, is normal, when you do tissue Doppler, it's going to be shorter. For grade 3 and 4, this is gonna get worse and worse, your tissue Doppler. So again, the tissue Doppler is very important for diastolic dysfunction. Now, when you put that pulse wave Doppler into the pulmonary veins, that's when you're gonna get this. In normal times, the S wave is gonna be taller than the A wave, and that like the reversal is normal. When you start having grade 1 diastolic dysfunction, notice how the S wave is not as tall. It's sometimes either the same height or a little shorter. Grade 2, it is much shorter than this D wave. Grade 3 still shorter, grade 4 still shorter. Now, let me move on to the next. This again gives you numbers, but this will be more for like when you start working. What you need to just be able to tell is whether it's grade 1, grade 2, or both of the restrictives. Remember, the doctor's job is to diagnose. Your job is to just kind of help point him in the right direction. Same thing, just a different format. I've put different ones because different people learn differently, and I'm hoping one of these will be able to help you learn what you need. Again, this is the final one I have. And this is perfect. I feel like this covers it. If I was going to use one to study, this would be the one that I would use because it tells you what's happening to the left atrial pressures. I would print this out if I started working and put it in my lab, just so I can quickly look at it and tell you where the dysfunction is. That's what I would do. All right. So this right here, if we were calculating the E to E prime ratio, you would take this 1.5 right here, and you would divide it by the 0.15. You would get like 10. And for this right here, you would take the 0.8 and you would divide that by 0.07 and you would get 11.4. This is just showing you how to calculate it. Remember, you don't have to do this. Just measure correctly and the machine will do it for you. But it helps to know how to do it. So the LA volume index. In order to get the LA volume index, you take the LA volume, which is what we get by tracing that planimetry, and divide it by the body surface area. So just keep that in mind. We don't normally do this. The doctors would do it, and some machines are able to, but the doctor, you don't do the LA volume index. You get the LA volume, and the doctor does the rest. So if you have an increased LA volume index, it means that the left atrial pressure is increased if the person does not have like mitral regurgitation or mitral stenosis. It could be a sign of diastolic dysfunction, and it means that the left atrial pressure has a really bad situation, like it's severely elevated or it's chronically elevated. For your LA volume index, if it's if it's less than 34 milliliters, we're looking at normal. If it's 35 to 41, it's mild. If it's 42 to 48, it's moderate. If it's greater than 48, it's severe. The machine will give you this though. So again, you can just put these in your lab or you can memorize these numbers. Remember one thing, a person could have normal LV diastolic function. They can still have left atrial enlargement if the person is a well-trained athlete or if they have like bradycardia. Also, if they're inputting a lot of blood, like if the blood is like if they have like a rapid heartbeat, and also if they've had heart transplant, if they have mitral valve disease, because remember, the mitral valve is preventing that blood from leaving properly, or it's bringing blood back in through regurgitation. If the person has AFib or atrial flutter, the reason why those matter is because the heart is not functioning properly, which means every beat does not export the same amount of blood. Remember the word planimetry. This was way back in page 110 of your book. Planimetry is simply when we trace this. So between apical 4-chamber and apical 2-chamber, you're able to get the LA volumes and you're able to get that index. Now, remember, it's annulus to annulus, and it's end ventricular systole, which would mean the LA will be an end like diastole. The left atrium will be the biggest, the left ventricles will be the smallest. Remember, it's end ventricular systole, and we measure from medial annulus to your lateral annulus. So try not to make a mistake there. All right, so these are your pulmonary veins right here. And this is your atrial reversal wave. And what we measure sometimes is that AR duration. And what creates this is the actual contraction of the atrium. When it squeezes, this is created. It's a temporary backflow. So remember, it happens at the P wave of the EKG. So what we're seeing here, this is the apical 4-chamber. We're seeing the right and left lower pulmonary veins. If we are in 5-chamber, we see the right and left upper pulmonary veins. So just keep that in mind. Sometimes you're going to see a S1, a S2, a D wave, and an A wave. But most of the time, you're just really just going to see like this S2 here. Just remember one thing. The S wave is peak velocity. We're going to, well, honestly, we don't measure that. But if the person has an issue, some doctors and some labs would want you to. But S wave, D wave, A wave, or AR duration, that's if you measure it. But this is the A wave, S wave, D wave, A wave. All right, so one of the first things we're going to get is that peak tricuspid regurgitant velocity. We get that from the RVIT, so it's one of our first measurements. If the person does not have right ventricular outflow tract obstruction, that peak tricuspid regurgitant velocity, as in this number, and the mean right atrial pressure is what's going to estimate that right ventricular systolic pressure. That's what gets it for us. Remember, we take this number, whatever the machine gives us, after it puts it into this formula. We're going to add the right atrial pressure, and we do that by looking at the IVC. When they take that sniff, remember earlier I talked about you would add 3, 8, or 15. So this number, this peak tricuspid regurgitant velocity, is going to be put into this formula. So 4 times the velocity squared. So let's say you got 2. You would put 2 in here. It'd be 2 times 2 is 4, times 4, 16. Yeah, 16. Sorry about that. I had to think about that for a moment. It'd be 16. Let's say they took a sniff, like a sharp sniff in, and the IVC collapsed greater than 50%, we would only add 3. So instead of 16, it'll become 19. And that falls under that normal range, so we wouldn't worry about it. Just keep that in mind. That's kind of an example of how this works. And indirectly, that right ventricular systolic pressure helps us estimate left atrial pressure. So when you see this regurgitation in apical four-chamber, you'd measure that, you get this number, we put that into the formula. We go straight and look at that IVC. So this IVC diameter, we measure that. Is it between, if it's less than 2.1, it's normal. If they take a sharp sniff in and it's greater than 50%, great. We add 3 and keep it moving. So remember, we want this when it's the largest, when the person exhales. When they inhale, it gets smaller. We don't want to measure it when they inhale. We want to measure it when they exhale. So let's talk about the Valsalva maneuver. You have 2 different phases of it. We have the strain phase, which decreases venous return, stroke volume, and cardiac output, and the release phase increases the venous return, the stroke volume, and the cardiac output. Remember, we are checking these to see if that person has restrictive feeling or if it's normal. When it's normal, when you have the person do Valsalva, this E wave is still going to be taller than the A wave, but it's going to be reduced. If it reverses, it means the person has a type of diastolic dysfunction. Just keep that in mind. So I need you guys to be remembering just these waveforms. I don't want to get too much into the technicality. Remember one thing. What we use Valsalva for is to tell if the person has a problem or not. If they have abnormal filling, if they have restrictive filling, and whether it's reversible or not. If it's normal, that EA is going to remain normal. Meaning it's going to be greater than 1 when you do that Valsalva. If they have diastolic dysfunction, the EA is going to be abnormal, which means it's going to be less than 1. So if you look at these 2, this first one is normal, this one is not normal. So when we're looking for diastolic dysfunction, these are the parameters that you need to focus on, and these are just the numbers on whether it's normal or abnormal. Now, if you're looking for 4 things, if less than 2 of the 4 are positive, you're going to want to, well, let's say 2 out of the 4 things are like positive. You're going to say it's abnormal. If less than 2 of them, let's say 1 was positive but 3 fell under the normal, you will say it's normal diastolic function. If 2 of them are positive, you will say it's inconclusive, but you can also, it depends on how bad you're seeing the situation. Because sometimes I say it's positive instead of inconclusive. but you can call it inconclusive. But if it's greater than 2, let's say 3 out of 4 of these things you're looking at are positive, you will say the person has diastolic dysfunction. If these numbers, 3 out of 4 of them fall under that positive situation, you will call it positive. 2 of them, you will say it's inconclusive, or you might say positive, depending on what it looks like. If less than 2, 1 out of 4, majority wins the vote, you're going to say it's normal diastolic dysfunction. So these numbers right here, whenever you're doing your studies, in order for you to name it grade 1, 2, and 3, these things have to happen. Go ahead and read them when you get a chance. But again, just because of the waveforms, 90% of the time you'll already be able to tell. Grade 3 diastolic dysfunction, if your EA, like if you get that EA ratio, if it's greater than 2, then it means that the left atrial pressure is elevated. You're going to have a short deceleration time if the person has a restrictive pattern. But again, this can be normal. Remember, as we get older, it tends to appear that way. Just make sure that you look at a few other things. Valsalva helps a lot. I focus more on that. But again, you can use your numbers. You don't have to memorize these. Just print it out and put it in your lab so it'll be easy for you to get to it. This is an EKG video you've seen before. I showed it to you in Intro to A&P. So think of this as a review video. I want you to re-watch it because you will definitely have questions about ECGs and the EKG, same thing, on your tests moving forward. And it's definitely going to be on your midterm and probably on your final as well. This is also a video about the cardiac cycle. You've seen this video before as well. Please go ahead and watch it. It helps deepen your understanding now that you're scanning on how everything ties together. This is a conduction system video, and it talks more about like your SA node, your AV node. It covers a bit about the EKG and the Wiggers diagram. All this stuff confuses people. This video does a fantastic job. Watch it as many times as you need to get the gist of it. You've seen this before, but it'll make more sense when you watch it now. If we were in person, I would show you a complete TTE video, but because this is a recording and I don't want to make it exceptionally long, that is why I'm skipping the videos. They will all be on your PowerPoint and you'll be able to watch them. So, remember, when a patient has AFib or a really, really bad TR, be careful about calling diastolic dysfunction because it might be those things that are causing it to appear that way. So, big thing. You see this MS? It stands for milliseconds. I don't want you to confuse it with meters per second, which will be M. There'll be a little slash right here, and it'll be S. So with diastolic function, it's going to be the dysfunction of it is going to be caused if the person has acute or chronic situations, if they have pressure or volume overloads, if they have lung disease, ischemic heart disease, congenital anomalies, cardiomyopathy, left ventricle diseases, and a few other things. We calculate it if the person has RV impairment, or if we suspect it, as if the right ventricle isn't functioning properly, or if we know that their right ventricle is not functioning properly. So again, the things we look at, the tricuspid inflow, the tissue Doppler, and the RA volume plus the RA pressure. Now, again, we need that tissue Doppler. And the apical four-chamber, but you would get this inflow wherever you can. Make sure that you're getting the maximum if the person has regurgitation. So we're going to be checking the pulse wave Doppler at the tips of the leaflets. You get an EA ratio, and then you get that deceleration time. Again, tissue Doppler. But at many hospitals, you'll find that the S wave is what they're looking for. Just keep that in mind. If your E to A ratio is less than 0.8, it means the person has impaired relaxation. If that E to A ratio is between 0.8 and 2.1, you're going to want to check a few other things. For us, print these out. Most people don't remember them offhand, and sometimes I forget them, period. I just want to be honest with you guys. We don't use M mode, but it's good to lightly understand what's going on. Linear measurements have become better than M mode measurements. So remember, this will be the RV free wall. From here to here will be the right ventricle. Here to here is the interventricular septum. Here to here is the left ventricle in diastole. And here is like the posterior wall thickness. Remember, this is systole. Interventricular septum, the left ventricle, and that posterior wall thickness again. Out of these, the important one here is this aortic valve cusp separation. This is the left atrium, and this is that root situation right here. But again, we don't measure in M mode. I have never taken these measurements in my entire echo career. So you need to know these. Even though we don't like measure anything, it's good to understand what you're looking at. It's on page 117. So before I start, let me talk about this. It's called your endpoint to septal separation. And if it's greater than 2 centimeters or 20 millimeters, it means that the person has decreased left ventricular ejection fraction and that their left ventricle is dilated. So you have your EF slope, which is number 1. They're showing it to you. You have your DE excursion, which is number 2, showing that to you. Remember, your mitral valve is supposed to close right after the QRS complex. Sometimes it closes at that R wave. If you have premature closure, though, it'll close before that QRS complex. Sometimes you can get a B bump, which is this bit right here. Before it comes down, it means that the person has increased left ventricular end diastolic pressure. But again, because we don't measure these anymore, it just kind of helps if you know it.